So, good afternoon, everyone. A very warm welcome to all our participants who are joining us today for the session 4 of our webinar series, Understanding Practical Bioethics. I'm Abhijit and I'm your host for this afternoon. As we continue this series, we are shifting our focus to a new and critical frontier in modern medicine. In our previous sessions, we navigated the sensitive clinical and legal landscape of end-of-life care. So today we turn our attention to the rapidly evolving world of digital governance with the introduction of the Digital Act, the way we handle patient data, ensure privacy, and manage clinical records is undergoing a major transformation. Today's session, Digital Act in healthcare, today implementation, implication, and practical use. It's designed to help you understand these changes and what they mean for you and your daily practice. So to guide us through this complex topic, we are joined by two exceptional experts from the Christian Medical College, Vellore. First, I'm honored to introduce Ms. Anisha Koshy. Anisha is an AI and medical ethics specialist at CMC Vellore, where she oversees the institution's AI and digital health governance initiatives. Her work focuses on patient agency and individual digital autonomy, with an interdisciplinary background in computer science, philosophy, and public policy, including prior roles in the Data Security Council of India with NASSCOM. She brings a wealth of knowledge in privacy, cybersecurity, and AI policy. And joining her is Dr. Joy Mammen. Dr. Joy is professor of immunohematology and transfusion medicine. And after doing a fellowship in pathology informatics in the USA, he now heads the biomedical informatics unit at CMC. Unit is a pioneering interdisciplinary effort to bridge the gap between medicine and computational science, with a specific focus on the use of artificial intelligence to improve healthcare delivery. So we'll have first Anisha will take us through the presentation on the Data Act, and then followed by discussion with Dr. Joy. The floor is yours, Anisha.
Thank you. Thanks, Abhijit. Thank you, Rupa. I hope my screen is visible. So the goal for today's discussion, as Rupa has, I'm sure, sent a primer to the group here, is to understand the Digital Privacy and Data Protection Act, which is right here, which is on the top right corner of your screen. In the larger regulatory conversations within ethics and generally regulation in the digital health space, we have a lot of regulations. And I know we don't have the scope to cover everything. So I've put whatever we can in the 10 minutes that I'm supposed to cover, at least to get a snapshot. So if you want to take a screenshot or, some kind of image of this, I think would be useful for the team to have. So we have there are medical devices guidelines that we have frameworks that have come out through ABDM, which is the Ayushman Digital Bharat mission. We have WHO guidelines that are more international regulations. There's NITI Aayog guidelines on responsible AI. Now that again is sector agnostic, but then, there are guidelines. Then there are CDSO guidelines, where software is seen as a medical device, or AI now is being seen as software as a medical device, right? So that's how it's regulated. But for the scope of today's discussion, we're going to stay with DPDPA, which stands for the Digital Privacy and Data Protection Act. Now, very simply put, it's how we regulate or how we think about digital privacy in this country. Now, privacy is a fundamental right, but digital privacy is unique. And the reason why digital privacy is unique is because the level of harm, right? In very simple legal terms, the level of harm that you can do with digital privacy is much larger. So, for example, if you as a physician are told a piece of information by your patient and then you decide to share it, let's say, with 3 or 4 colleagues, of course there's harm that's done because the patient's reputation could be on the line, or they could be discriminated against if someone else overheard your conversation, etc. That there is a sense of liability around that. But let's see if this is not limited to just 2 or 3 colleagues. Now, this is a digital system on which a bad actor could come and release a whole bunch of this patient's private information for, for the highest bidder to buy, or they just want to be malicious and leak your medical information. Let's say the patient has some condition that they don't want to talk about, or they're in a situation where, if members of their family found out that they had an issue, they would be treated badly or, harmed in some kind of way. Or if there are certain types of disorders, especially with psychiatric and mental health disorders, employment becomes a big challenge. So the level of harm that you can do if your personal information was available online is very, very large compared to what it could be if it is not available online. And that's precisely why the law is called digital privacy and data protection. So that's where the whole concept of digital privacy comes out. Now, for the purposes of today's conversation, I'm simply going to be introducing a few key principles that we have in the law, so that we understand it a little bit more systematically while we go into talking about things around ethics. So, in India, the physician usually works within an institution, and the patient comes to that institution, passes on some of their private information. Private information could be anything. It could be your name, it could be your phone number, it could be your address, it could be your gender status, it could be absolutely anything that pertains to you that can be uniquely identifiable as information pertaining to you is personal information. Now there are degrees of it. There are sometimes more sensitive information, sometimes less sensitive information. Sensitive information would be something, let's say, like your let's say you have a certain disorder, and that is sensitive information. Your banking information is considered sensitive information. So there are risk factors again, right? So risk is a big thing that we want to think about when we talk about data protection. For, let's say, for someone who, your name, for example, is not sensitive information, but let's say your relationship status could be sensitive information. Now, if a patient were to come to you, the patient in this conversation is called a data principal. They are the people that hold the data. It is their data. They come to you and they confide in you, they give you information. You are then considered a data fiduciary. And there's a reason why you're called a fiduciary. You don't own the data that your patient gives you. You don't own the data that your employees give you. You simply are holding on to it. You are fundamentally a bank. You are a repository that holds this data safely for a period of time. Now, for how long you hold it is decided by different things called retention periods. But your only job is to keep that data safe and not misuse that data while that data is in your hands, right? So you have a data principal who is the patient or the employee or the person, individual, essentially, who's coming and giving you the information, and then you have yourself, which is the data fiduciary, whose job is to keep this data safe. So this is the relationship fundamentally. And now, as the data fiduciary or as the person that is holding the data, you have a lot of responsibilities. And those responsibilities in legal language is called liabilities, right? Simply because if you don't do your job well of being responsible for this data, then you could be held accountable, right? And who would hold you accountable? Under the Data Protection Act, you would be held accountable by the Data Protection Board. Now, for the purposes of this conversation, I have to say that the Data Protection Board is yet not set up. We do have rules that have come out that says that the board will get set up and how the board should be made up and who comprises the board, etc. But as of today's conversation, we don't really have a board that is fully set up. Right. So that board then decides, you as an institution, did you do the right things? Did you protect the data? Did you take due diligence in how you were collecting the data, right? So there are responsibilities that now institutions have to follow. And the data protection law is fundamentally that set of instructions. That's all that it is, right? And you start with high level instructions, which is things like, make sure that the patient's autonomy is protected. Make sure that, there is no ill will when the institution is collecting it. If you are collecting the information of vulnerable populations, let's say children or, folks that have certain kind of disabilities that can't give consent, etc. So how do you protect, those individuals? So it can be a set of rules like that, or it can be very straightforward. It can be things like, this is how long you can keep data. After this time, you have to delete that data, or the purposes for which you collect. So for example, let's say we as an institution, when we collect data, we have to make it very clear to the to the patient for what purposes you are collecting, and the term for which it's called purpose limitation, right? So the purposes for which you are collecting. So if I am collecting information when the patient comes to my hospital, for the purposes of giving care, right? So for the purposes of treating the patient. Now I decide to keep that information and continue to hold on to that information, but use it for things that I didn't tell the patient I'm going to use it for. That could be things like analytics, that could be things like marketing, that could be maybe selling this data to a third party actor. It could be anything. If I do any of that, that goes with outside of the scope of what I've told my patient I'm going to use this data for. And that is a violation of purpose limitation, right? Even collection limitation. You collect only the information that you need to do a specific activity. Let's say a patient comes to the hospital and their only requirement is to be seen by one department for a small procedure and they leave, right? You collect only the information that is necessary. You do not have to collect, let's say, historic data. You don't have to ask them for a million medical records on other things. You don't have to, let's say, for example, if they're wearing a wearable, you don't have to get all of that information. None of that is necessary for the purposes of the treatment. So identifying the problem for which you are collecting the data and then keeping only that is vitally useful. So that could be something like storage limitation. So there are principal level, broad ambits of things that are going to get covered. And then there's, more prescriptive things, right? So that is kind of how the law is broken down into. But for the purposes of this conversation, this is a national level regulation that is sector agnostic. So it's not written specifically for healthcare. It's written for all sectors. So by the nature of the regulation, it's very, very skeletal. A lot of this will come out through rules. And one of the things, so just last year, we had the first set of rules that came out for the DPDPA. And the first set of rules spoke about something, let's say, for example, consent. That is a big conversation, and we could do a whole session just on consent and notice. But for the purposes of today's conversation, I'm going to quickly talk about it because that's the first regulatory hurdle that we will all face, because the deadline is November of this year. So notice and consent. So do we actually let our patients know at the beginning of their treatment journey what the data is going to be used for, how we're going to collect it, how long we're going to keep it, and when we're going to destroy it? Do we tell the patient all this when the patient comes to the clinic? Do we make it evidently clear? Do we have even internal structures where we know this is all we're going to keep the data for, this is where we're going to store the data, after purposes of usage we're going to delete this information? Do we internally have clarity around these things, and like a policy internally, right, for something like this? And then do we make it evident to the patient? Do we give the patient then choice, right? We can always tell the patient a story of the notice, but then do we give them a choice? Do we say, okay, these are things that you can say yes to, these are things that you can say no to? Are these systems that we have provided and giving? So these are all some of the things that we will start thinking about, I think, more in detail as the session goes forward. And I'm happy to answer specific questions. But based on Dr. Rupa's instruction to me, my job was to kind of just present the idea of what the DPDPA is, right? And very simply, it's a set of instructions on how institutions can govern data. For the purposes of a hospital, it is how do we govern patient data and employee data that we hold, right? And that is only when it comes to personal information, not just general information. If we know that this is identifiable information that pertains to a specific individual, how do we protect it? What are the steps that we need to take? What are the compliance aspects that are necessary for us to fall in line with the regulation? What are our timelines? So this is a much larger conversation, but I just wanted to present the idea of what it is and where we can maybe even start thinking about it. So I would say start thinking about it in terms of consent and who we are in the ecosystem. So are we a data fiduciary? What are our responsibilities? Where does our data lie? Do we even examining ourselves and asking, do we have a governance mechanism? Do we have an internal data governance mechanism? Is it up to date? Right? A lot of hospitals do have internal data governance mechanisms, but is it up to date? So that's another question. So just kind of getting the feel of the land is I think all I'm able to do in the crunch of 10 minutes. But I'm more than happy to answer any of the questions that Dr. Rupa might have for me.
Thank you, Anisha, for that timely presentation on the Digital Data Protection Act. So I know that participants will have questions. So Before we get into the questions from you, we would request you to put them on the chat box. In the meantime, I'll request Dr. Rupa to take a few questions with Dr. Joy for the discussion. Over to you.
Thank you, Abhijit, and thank you, Anisha. Yes, it was a very crisp and very short of a presentation, just to at least have a have an input as to what we should be at least thinking about when we talk about the Digital Protection Act. So, good afternoon, everyone, once again. And as we navigate this rapidly evolving digital landscape, it's also essential for us to understand the regulatory frameworks that govern this. And this Digital Act is definitely a landmark judgment that has come to the aims of the shape of the future India's digital ecosystem. Now, going forward, I think the first thing, Dr. Joy, I would jump into is the practical aspects for the same. So, what are the steps a hospital must take to comply with this Digital Protection Act? If you could just start with that, to be more practical, I think.
Yeah. Thank you, Dr. Rupa. Thank you, Anisha, also for the bird's eye view and the short discussion. Today's discussion is not the official position of CMC. These are things that we have read, discussed, discovered for ourselves as part of our work in helping the institution to create governance documents and frameworks. So I think the first thing for the institution to do is to actually read the Act itself. It's not too long, only 21 pages. And today there are so many explainers available on the internet also. So there are good sites which will give you reliable information. So the first thing is to read the Act and understand to the extent possible. I know it's difficult for us to read regulated documents, but I would really encourage reading it because these are not like the old acts. Many of the sections actually have illustrations written into the Act itself, so it makes the reading easier. And these are all real world examples that have been used. So that's number one. The second thing is, I think the institution to take an inventory of where digital data is being produced and to what extent. In some of our hospitals, we might still be completely paper-based. Some hospitals might have 100% electronic medical records and digital workflow. But I think for the most part, we are in a hybrid mode. At CMC, we ourselves work on a hybrid mode. There are some parts of our systems which are still paper-based for either for the clinician's convenience or sometimes for the patient convenience and to help our workflow management. And especially in the inpatient side, we are still mostly paper-driven. So we should remember first that this Act applies to digital data. So it's not necessarily covering our paper data that is collected and retained by ourselves. So the first thing is to get an inventory of where you're creating electronic data, where it is stored, who can access this data, is this data being shared externally, and how long you're retaining these data instances for. So that's one basic way to start off within the system. The other side of it is to, when you read the document, you'll realize that there are new processes or unfamiliar processes that are now being introduced. In the IT world, these are standard, but when we adopt some of these digital processes within the healthcare scenario, sometimes we just bypass these. For example, a data audit or a data impact audit is an important process. Most software companies would do it for themselves, but I think that most of our healthcare facilities may not have performed, and giving us all the benefit of the doubt, may not have performed this. So it's important to perform data audit, data impact audit, to understand where data is sitting, who's accessing it, how do you protect it, do you have role-based access? Is it possible to audit these role-based access, or is it like people share passwords, or there is a common password which is just left on in the computer all the time, and anybody who wants it just clicks, opens, and views and does the work that is required. The other thing is to identify which are the new offices which need to be created. There are some new roles and responsibilities that are defined. You will need a data protection officer. You will need, if you're a larger organization, perhaps you need to create an office with people inside that office who will look after the all these processes and procedures that are being followed and documentation that is required for you. And as Nisha mentioned, I think consent is an important part of this. So we need to review our consent and see how we are taking consent, how we are recording it, and what is the information provided to the patient. The last thing I would like to speak on is security. We all know about the need for data security, even with like where there are personal experiences of people being pulled or hacked, or your data or your email being accessed by other people who are not authorized to. But here now we're talking about the entire hospital health system, and you need to make sure that there is adequate encryption, there is backup, and you have security in place to ensure that there is antivirus which is actually active, updated, and you have a system to make sure that your systems are constantly updated, patched, and secure for use. So I'll stop over there. I think the main highlights are the fact that you need to manage data. You need to have officers in place and officers in place for this. You also need to list out the processes that are procedures that are required and make sure that you implement adequate security.
So, thank you, Dr. Joy. And let's say we want to implement the data. So there might be, like you said, there might be hospitals which might be doing it fully, they might partially, or actually, or in the process of thinking that they're going to do it. So how do you think this new act is going to impact the consenting process? Like that's one of the main process, like, right? So.
Yeah, Anisha, you want to have a first go at this?
Has two components, as we say. One is notice, and the second part is consent. Notice, essentially, if you want to think about it, it's like terms and conditions, right? It's like the thing that you release on behalf of your institution to the patient, saying, these are all the purposes for which we will collect and use your information. This is how we will store it. This is how we will delete it. That is the most basic framework. Obviously, it may get more or less complicated depending on, what purposes we're going to use it for. Are we going to use it for analytics? Are we going to get third parties involved? How much processing gets done on it? Are you going to use it for research? Are you only going to use it for clinical information? So there's a lot of different factors to it, but notice fundamentally is just a document. It's the document that explains to the patient that the purposes for which their data is collected and is going to be used. And ideally, it should be the first thing that they interact with when they come into the hospital, because from the first point of interaction, you are going to collect personal information. It's just the nature of how, we operate now. So if you're going to collect any information, let's say for banking or for, slips to give them to go to pharmacy, anything that's digitized fundamentally, anything that's not paper-based, right? Unless your system is 100% paper-based, you can't avoid having notice and consent. Even if there is just one component, let's say you have packs, so even if there's just one component that's digitized, you will still have to tell them that, for, let's just say they only have radiology, which is digitized, you still have to tell them, for the purposes of radiological analysis, etc., your data will be collected, kept here, stored here, right? So that clarity, that data, that the sheet that we give them, the information sheet fundamentally is called notice. Upon reading this notice, the patient then has the right to say, yes, I consent to giving my data, or no, I don't consent to giving my data. And now we use a terminology which is called itemized consent, which means that you can't give a long notice saying that, we're going to use it for clinical purposes for treating you. We're also going to use it for research. We're also going to use it for an analysis. And the patient just signs one, consent, yes, at the end of it, right? We have to give them something which is itemized. So we say, okay, do you consent to using your data for clinical purposes? Yes. Do you consent us using your data for research purposes? Yes. Do you consent to us using the data for marketing purposes? You can say no at that instance, right? It still doesn't affect their level of treatment or how you would continue to give care. It just gives them more of a right, or, to exercise their right to privacy. It just gives them more of an access to do so. So consent is the mechanism by which they give you permission. Notice is the document that goes out, and you ideally have to do this right at the beginning of when they come in, and you have to collect it and keep it in a manner where, let's say today that the patient says yes to their data being used, tomorrow they may say, no, I want you to remove all of my data, right? You've given me the treatment that you need to. I'm all better now. I don't need you holding on to my information. We should also have a mechanism to revoke consent. So that means we should have a technical mechanism where we can go in and remove all of this patient's information that is stored in our systems. Right now, obviously, we cannot do this 100%. We just have to do this in spirit, really. That, in systems where it's really obvious, we have to take the patient's information out. So this is broadly and very simply the consent and notice mechanism. I'm happy to answer any more specific questions if you have them.
Can I add a couple of statements more to this? I think there are some pragmatic issues in this. And one of the unique things about this act is that it is agnostic to sectors. This act tries to cover all kinds of digital data, whether it's a commercial transaction, you buy something on Flipkart, or whether you go to a hospital or you go to a bank and you transact with it. So the act covers all kinds of data. And we know that when we collect data in our outpatient or inpatient scenario, most of our discussion is around the patient's immediate problem, but we're also taught in medicine to take relevant past history and to record. So there will be history that we collect for the patient, which is might at that point appear irrelevant, but there are significant negative and positive histories that we do collect and we need to collect in them. So there are sectoral guidelines, laws, and rules also which will overlap with this. And where there are sectoral rules, we will have the ability to follow sectoral rules. So for example, if in a blood center we collect donor information, according to the Drug and Cosmetic Acts, we are supposed to retain it for 5 years. So even if a donor actually writes to us and say, I want to withdraw consent for the data, there is actually a sectoral act which says that we have to hold on to it for 5 years. And so we are not obligated to, we'll have to explain to the subject, but we are not obligated to delete the data. Similarly, I think under Clinical Establishment Act, there must be some data retention period. NABH suggests, I think, 7 years to retain data. If it's medical legal, we are allowed to retain the data for practically forever, or at least until the case has been resolved satisfactorily to all parties. So there are exceptions to these, and we should make sure that we are addressing this in a comprehensive manner and not stress out about immediate withdrawal of consent and removal of data. If the patient is under treatment, then we do have the right to retain the data for that patient while the patient is under treatment, and especially if there are chronic conditions and the patient continues to visit, then you have a logical reason as to why we are going to retain the data for that patient.
Thank you, sir. And so I think there were a few questions on the chat already, which said, how do we take consent? So that's covered in that, but there's another two specific one related to consent. So I thought I'll just add on to that, which is, so medical legal cases, do we specifically, what about those? So do we take consent specifically in patient that we would be sharing these data to the law enforcement agencies if required? That would be one of it. And the second one was that, so I think yes, right? That would be the answer, right?
That is the answer. That's correct.
Yes.
Yeah. We are obligated by law to report these certain types of cases. So
yeah. And so Anisha, and are there any general or standard notices or consent which is available for these online, for the data collection or the consent rather? Is there something like that available?
Yeah, certain institutions do publish it. So my previous institution, NASCOM, for example, does have frameworks that they put out for different sectors that is publicly available that you can go look. Obviously, we'll have to kind of tailor it for our specific institutions, but they're called standard contractual clauses. And NASCOM is one of the folks that do it. I think Deloitte puts out a yearly one. Ernst & Young puts out a yearly one. And there are a few of the law firms as well. I'm happy to share some with you specifically, Dr. Rupa, and then you can share it as well. But yes, there are publicly available ones that, then your internal law team can take a look at and tailor for you. But yeah, standard contractual clauses for consent and notice exist, yes.
All right. So we would get that from them and then we'd put it in or send it across to the participants. There's one more which says that in the Data Protection Act, so the data provider has the right to ask for the data to be deleted. So how do we go about deleting all the patient data? Is there anything specific for that?
Not really. It is part of the design that needs to be built into the system, and retrofitting current systems will come with its own challenges. It depends on how databases are designed and how systems have been designed to make sure that you can single out a single patient's records across years and longitudinally across various times. So it is. I don't think it's going to be an easy task, but I think going forwards, we'll have to think about that also. And if somebody's in the business of starting their EMR efforts or looking for an EMR, that should become a criteria going forward to ask your vendor, how do you make yourself compliant with the new DPDPA Act to withdraw requests? So it's really not as simple as going to Amazon once and purchasing something and then to be able to just remove that trace. So it is going to be challenging for us. But I think we have to, on the one hand, when we take consent in the beginning, we have to state it to the patients that we take consent with the intent of treating patients long-term and this thing. And so therefore all relevant data will be collected. We all go into this hoping for a smooth relationship, really not going backwards and trying to remove data. But things are going to change in the future.
And so do I have to give proof that I have removed the data or destroyed the data on the, like if the person revokes the consent, or is it just like something written? That's one of the questions also which is there.
Yeah, I'm just looking at that question and trying to figure that out. I do not know whether we are obligated to give proof. We are obligated to give a report. Then I suppose we have to confirm that yes, we have revoked the access to that data or removed the data from our systems. I don't think there is anything which says that we have to give proof of destruction. In any case, what kind of proof would we give? We can't be. It's not like an Excel sheet and we can take screenshot of before and after and send it back to the patient. So we'll have to give declarations, and some of these might, if somebody decides to litigate and take this to court, maybe there are ways to do forensic audits and discover where these data are sitting. But I think in the straightforward look of it, I don't think we need to give more than assurance that we have removed the data.
So if I may add one more point of this data removal thing, Sir is absolutely right in that in the regular situations we don't have to really there's no proof of burden really, but we do have an obligation in the law which is to conduct yearly audits. So we're supposed to do something which is called the DPA, which is the Data Protection Impact Assessment, and there are audits. They're essentially data audits that you need to carry out. And if you have an external auditor. And if there is a removal request that has come and then we can't, there are mechanisms that they have to just generally check if you've been compliant. So yeah, while we might not have to tell the patient themselves, we just have to give them a declaration. But it is best practice to have some mechanism for removal or taking it out of your system only for the purposes of the audit, not the patient directly. Yeah.
I think that's a very good point, Anisha, because that would give both the patient as well as for us a kind of a compliance that we've taken that whatever request had come and we've done that also. So
correct. Yeah.
That's a counter check mechanism. Thank you for adding that. So if I may ask, like, how will this data retention be affected? Like usually we retain so much of like patient information. So how will it be actually practically be affecting most of the healthcare system, like now that it's just going to be digitalized?
I think going forwards, hospitals that have legacy data will have to undertake some process of informing the general public and specifically its patients to say that we have retained past information of your visit to the hospital and your treatment undertaken with us in digital format. and they will continue to be retained for your clinical purposes. I'm hoping that we'll get some legal advice around this. This is not legal advice. I'm hoping that we'll be able to find some kind of a via media for that, because we do not know when the patient is going to come back and expect treatment. All of our patients are not equally literate and are not going to be instantly aware of this Digital Data Act and the retention periods which are changing. So we have to work out some mechanism of informing patients that we are holding their digital records for the purpose of continuance of care for them. That is what I think that legacy hospitals with legacy data will do.
All right, sir. So then what about personal health information or some sensitive data? Like sometimes it's very even earlier we were noting it down in the file system, but now that it is going to be digitalized and maybe access or hacking, or like those are the health hazards, or like system hazards that we talk about. So what are the sensitive and private data that if we are talking about specifically?
I think if I'm not mistaken, we do not, in the new act, there is no such category of sensitive PHI or personal health information. All data which is linked to the individual are considered as personal digital data. Once you digitize data, it is considered. Now, you can, I think there are ways to differentiate more significantly personal data like HIV status, a disease status, or a mental health status, those kind of things, as Anisha was mentioning at the beginning. One of the things that we have to do is that we have to do our due diligence and show best efforts to comply with the act. So how did we do a data security audit? Did we create systems which has username, passwords, and data accessible through defined roles? It's not that everybody needs to access all data. Even in CMC, we have restrictions on data. The clinician, doctors, the physicians have most access to almost all the data which is available around a patient. Me as a pathologist have certain data sets which are data which is available to me, but if I wanted an OP record or sometimes an IP record, I need to go through a permission process in order to access it. The lab techs do not have access to EMR data and medical reports, research summaries, and lab results, unless in the line of work they are required to do so, which means they have a username and password. There is a way to specifically access this. All people do not have rights to prescribe medicines. So there are restrictions which are built into the system, and such restrictions actually show that you are concerned about how people access data and how it is being recorded and audited. So that's the first step of it. The other thing is to make sure that there are data security at this DPI, the data impact audit is done systematically. We'll probably end up having to get external consultants to do that. And then to have a record to say that, yes, we have complied with these kind of activities. So I think even when somebody litigates or takes us to court, finally, I think there's going to be a view of how much have we done to become compliant, what are the procedures that are in place, and then I think appropriate action will be taken.
So I think just to put it as a synopsis, the audit and to put systems in place, that's one of the first steps that each of us have to be
compliant. Yeah.
Compliant to. So just adding a few, from the few questions that we've got. So many of these journals, they require data disclosure, and the authors are expected to share data on requesting. So is that a risk according to this act?
No, I think we are allowed to conduct research. We can de-identify or anonymize and use data for research. There's provisions for that in the act. So we should now become clear as to where identified data is stored, what is the process for de-identification, and how do we ensure that we have verified that the data that we are using for research has been de-identified. How do we test it out, or how do we do the quality assurance for that also? So in future, different types of, it also depends on how the data is set up and extracted from it. If it's like an an Excel sheet and one column contains the hospital number, then potentially you will be able to replace the hospital number, mask it, or update it with the study ID and change the ID. And then based on the type of study you're doing, if you are going to have a key and it's going to be locked away or encrypted, then you should state in your research proposal how you're going to do it. And you will have to submit this to the IRB, and the IRB should give you permission to do it. And every IRB obviously asks, why do you collect data? What is the relevant data? Data minimization is something that all IRBs do. They try to see what is the data that is collected, and is it relevant for the research, and only then allow the data to be extracted from the system. And the last thing related to that is that, yes, we have to be careful about how we handle the identified data before you de-identify it also, and make sure that you write in processes to say that once the data is de-identified, you will make sure that if there is a key, the key is secured. And if there is an older copy which is identifiable, that needs to be destroyed, and there should be processes to do that. Making data available to the research community or to the publishing journal, yes, that's a practice now, and it's de-identified data that they ask for. The government itself is also looking at making publicly funded research data to be accessible to the rest of the community for further research and development. So nowadays, ICMR and DBT and DST, all of them make it a point to say that once you finish your research, there is a quarantine time available for publication of a patent link. But after that, the data has to be put up on public access portals like the AI Koshy, for example, is one of the sites where data is becoming available.
All right, sir. So, like, let's say the system gets hacked or there is non-compliance for whatsoever reasons. So, do we have penalties for that? And how is it actually, how is the liability assigned for all of these?
Anisha, you want to take first go at that?
Sure, sir. Yes. So there are penalties, and I'm refraining from saying the number because I think every time I say it, people get scared. So the penalties are usually for a couple of grave misgivings. So it's things like, we've actively made sure that you've done no due diligence, and then there's been a leak of information, and that type of thing. So it's a data breach. And then so data breach is the biggest possible penalty that you could get something for. That's around 250 crores. Then you also have other types of penalties. So it could be things like, let's say you had children's information and then you didn't do due diligence around it, or you had large volumes of information, let's say something that was pertaining to, let's say, sovereignty and national security. I know these are sometimes esoteric terms, but that's the letter of the law. So you had information and you weren't careful with it, then that could also invoke penalties. So there are penalties attached to it, but and this is more of a deterrent. That number is more of a deterrent to ensure that people comply, and it's less of a enforceable number. It's more to ensure that folks fall in line, and due diligence is taken at all stages. It's I would like to think of it that way, and less of the less fixate on the actual number. Yes.
There's a question about portability of health data. Can I address that?
Sure.
So essentially, I think the government's view on this is that all of us become compliant with ABDM requirements, Ayushman Bharat Digital Mission requirements, where portability is one of the key drivers. So when two health systems which are compliant to ABDM requirements, then there is an entity in between this called the consent manager. So if a patient comes to my hospital first and then goes to hospital number 2, both of us are ABDM compliant and are working with interoperable standards. The patient will be able to, the doctor at the second hospital can initiate a request. The patient will, the consent manager will contact the patient to say that said doctor has made a request. The patient can give the permission or disallow permission. If the permission is allowed, then the data can be made accessible to the second hospital. In the current scenario, it is for viewing, but there are also going to be in future questions about whether the data gets downloaded locally for future use and future purposes. And then the patient in this newly envisaged system will have rights to say how long the second hospital should retain the data and who has rights to it, etc. It's an ideal system. It has been demonstrated in conceptual presentations. I've seen some, but how it will work pragmatically on the ground is yet to be seen and realized. So portability is envisaged. Currently, I think one of the safe ways of doing it is to encrypt a file and transfer it, use safe email systems, make sure that you're sending it to the right person, that the patient who's receiving it has given you the email at the time of registration, or as in some form validated that that is the email ID which they are using. I would strongly not recommend using things like WhatsApp to just casually transfer, because we do not know whose WhatsApp it goes to. It's easy to make mistakes on WhatsApp. There are groups, files can get shared, all kinds of unhappy things can happen later.
Thank you, sir. So there's one more which says that there are so many people who actually share data with without revealing patient identity, but you post these images and interventions on social media like Instagram and Facebook, even WhatsApp, like you said. So will that be considered a violation or a punishable offense actually under this act?
I think under the strictest sense of it, sharing on social media without explicit permission from the patient is a violation. So people now take it very casually, especially within healthcare organizations. These tools have become almost like necessary for routine work and routine or fast tracking work. It saves a lot of time. People do not have to move physically between locations. But when you look at it from the perspective of the act, yes, there can potentially be liabilities if somebody sues you or takes it.
So yeah, that's true. Like there's one saying that sharing on social media is unethical, even if it's masked and unidentified. That's very true, like what you've written. And I don't think so. There's a specific place in the act which says that. It's more to do with understanding it ethically, that it is wrong to do that, and so it is even ethically wrong. Even through the NMCs, that you can't advertise with the same, because a lot of people do that for advertisements.
Yeah,
so even that is, yeah, that is absolutely not allowed. So do we have an indemnity insurance for something which is available for it, for saving us from the crows in case something goes wrong?
I remember reading something from, I can't remember, those General Insurance Corporation, or Anisha, you can pitch in if you know something. There are digital insurance policies now available to hospitals, but I've not done enough reading around it to advise. Yes, there is potential for covering yourselves with insurance.
Okay, there's just one more question which is there in the chat box, and I'll hand it over to Abhijit after that. So, do we have any rules which specify that which data is getting collected for what? Like, for example, you collect the data for the diagnosis, and then can that be like you find it interesting, and can that be used for research later on for some reason?
So you have collected data from the patient for clinical purposes and data you want to use it for research.
Yeah.
Is that the question?
Yes.
Yes, I think we can do it. We have to go to the IRB and ask for permission. You have to get a institutional review board and ethical committee clearance. And then the ethical committee will decide whether it is okay for you to extract this data without going back to the patient. But if you're going to identify a list of patients from this and then take prospective data, you will have to reach out to the patient and get consent from. If you're going to identify patients and then contact them, all these are patients who had history of diabetes, taken a particular type of medicine, or had a type of device implanted in them, and you want to know 2 years down the line how they are doing. So then you will have to get IEC clearance for your study, then reach out, get consent in a documented manner from the patients to say that are they willing to become part of the study and provide the information going forward.
I think it's like almost same as how we were doing it when we were doing on a paper format.
Yes.
You collect, you see the patient for a purpose, but then ultimately you find that there is some interesting finding and you want to do a research, you will have to go back and take the consent from the patient, either the consent or the review from the IRB for doing a research ahead.
Yes,
All
I
right.
did.
So those were the basic questions that we wanted to put forward. Abhijit, do you have any questions? Any more questions?
Yeah, we received few questions during the registration process. Few of them, what we'll do is I'll just put them through. Either sure Anisha can respond to it. So I've just grouped them so that it's easier. First is on the legal landscape and the statutory requirement. So overall impact of Digital Act on our healthcare system today. And are there statutory regulations in India mandating all providers, government and private, move to EHR or digital data? And are digital reports and prescriptions without physical signatures acceptable in a court of law?
So many questions. Yeah, there are many questions rolled into one. I'm a little nervous about taking on these complex questions. I think we reached the top of the hour, Rupa. I'm hoping that we can have a future engagement with more clarity and addressing more questions. But I think, generally speaking, be cautious, take consent, and especially for things that you're sharing on the net, like a digital prescription, for example. You have to make sure that there is a way or to authenticate and make sure that people know who's the patient for whom prescription is being given. And when a prescription is being given, there are certain Drug and Cosmetic Act rules which come in to say that certain things can be prescribed, certain things cannot be prescribed on the net. And there are also telemedicine rules which provide some guidance around this to say what you can prescribe and for whom you can prescribe and how often you can do a refresh on those prescriptions. And then institutions have to develop their own protocols around it to say, I will allow 1 refill or 2 refills. And then subsequently the patient has to come back to be seen before the 3rd refill.
And the next one is, are there statutory regulations which are mandating that all providers move to EHR or digital data?
I don't think there are any regulations yet, but certainly, yes, the government is pushing people to move towards digital platforms. And if you, I think there are different types of pressures. I think those of us who are medical colleges, the government has said we have to become digital. And there is an opportunity. They have given some names and some providers who are listed on NMC site, including CDAC's own product directly. So yes, the government is pushing towards moving digital in the hope that all this data will become digital, and then perhaps all payments will become digital, and there is more control and visibility for the government also as far as this is concerned.
There were a few questions on the safety, security and privacy. I think those have already been answered, so I'll not put them here. But in terms of the compliance and penalties, what are the specific responsibilities of nursing colleges and hospitals regarding student data, Aadhaar, and biometric attendance?
Is that covered in the Act?
Yes, yes. Employee data is covered in the Act. So I think I'm just going to share my screen here. I wasn't able to share this presentation before, but I think this kind of, I'm sorry about the sizing, but I think this kind of gives us a feel of, these are the 12 steps. If you had to start your compliance journey, this gives you a screenshot of where you have to start. You have step 1 and step 2. So all the ones on top start now, right? So there are things like privacy, data mapping, governance, lawful consent review, etc. I've shared this in the chat as well. This should help you understand, or at least think about, okay, these are things that we already have, or these are things that we don't have and we need to start thinking about now. I don't know how useful this is, but I have shared the same. Just for the sake of the conversation around nursing students, yes, their biometric information is personal information. All of the purviews of the law still apply to them. If they are students less than 18, if they've not yet completed 18, then they're considered children. So they have some additional obligations under their data. But once they've crossed 18, then you don't have the child obligation, but you still have all of the other, the scope of everything else still applies to them. Your employees are covered exactly the same as your patients would.
Thank you, Anisha. We will be sharing this presentation and the recording with each one of you. Those who have registered, we will be emailing it to you. And there are other questions in terms of the AI part of it and ethics part of it. What are the potential adverse effects of AI in a healthcare setting? And how effective is AI when compared to human touch versus traditional healing? So these are generic ones which usually we get for AI.
So I'd take a step back. AI is it's a very generic term used for a bouquet of technologies. All AI is not the same. All technologies are not AI either. So we should be cautious when we're using that. There are very few technologies which have actually become mature enough to use directly for patient care. Radiology is an example where patient care has benefited by it because you can have AI to screen a chest X-ray, for example, and give an interpretation. So there is limited use of AI. Some people have started implementing AI for clinical solutions. And there are other situations where AI can enhance certain imaging modalities. And these have also sometimes come built into the modality themselves. So the newer CT scanners and MRI machines, which are bought within the last 2 or 3 years, have these modalities built into it. So sometimes we might not be aware, but there might actually be an AI component which is actually doing a measurement or refining an image or making an annotation on the image which you thought was, you did not know was actually AI. That's the first thing to think of. The second thing is that when you're using AI in a direct patient care scenario, then you should be knowledgeable enough about it. You should have evaluated the product in your own system to know what are the ins and outs and the sensitivity, specificity, or whatever metric that you need to use for it. You should have demonstrable evidence with yourself before you implement a solution that uses AI. There are a few AI-based clinical decision support systems which are available. Again, before you implement these, you should make sure that they are right for you. It's been demonstrably validated in our population using Indian metrics or Indian type of data before you implement this. So like any other tool that you would have brought in beforehand, there should be a process, how you select, how you validate and test it, and then how you implement it. And then after implementation, there is also a requirement for post-market surveillance. That means you'll have to continue to surveil these tools because we all know that they have more capabilities than we know of. So therefore, they can also make mistakes. You should continue to make sure that you have a way of quality assurance after you've implemented it. So the government is now using the Drugs Control Agency as the licensing authority for AI-based application products. There is draft guidelines out. There are, as earlier on in the presentation, Anisha talked about software as medical devices. So even AI software, which is being used for patient-facing or therapeutic or diagnostic measures, have a higher degree of compliance which is required. And appropriate proof should be shown, and then the CEDESCO will license it to be used within the country. So there is a certain framework which is available. Everybody is building capacity. The drug controller and the Indian Pharmacopoeia is also working on this. and other bodies within the country also working to see how devices and applications which are used for healthcare can be regulated, and what is the obligation of people who are using this. So currently it's divided. There are people who say the software developer should be responsible. There are people who say the doctor should be responsible. And so I think it will finally become a divided or shared responsibility. We should all be aware when we go into these products as to what the expectations are. Summary, I spoke so much because the way ahead is not clear. We are also feeling our way through it and being cautious enough.
The next set is on the impact on patients and healthcare professionals. So, what are the top risk and need to know facts for patients regarding digital healthcare? And how will these digital tools specifically assist or change the nursing profession, or maybe healthcare workers if we look at it in general?
So is the question on digital tools or AI tools? Because they're two different, I mean, like all AI tools might be digital tools, but all digital tools are not necessarily AI
No.
enabled.
No, I mean digital.
I would say that, for example, within our generally healthcare has adopted digital platforms to make patient care streamlined and easier to deliver. We really have not gone back and looked at all the data that we have collected and utilized it to influence our patient health or to do great research from it. Lastly, it has been in terms of finding an appointment, registering them, moving them along the payment pathway, doing the test, bringing back the result into a digital system so that things can be fast-tracked, we do away with paper, and we become more efficient. So efficiency and turnaround have been the greatest drivers of adopting digital health platforms. So that has had its benefits. Now, we also hear of complaints from both sides. Sometimes patients say that the doctor keeps looking at the computer screen instead of paying attention to me. So there are deficiencies in our current modalities. The interface is still the keyboard and the mouse, so it is challenging. Maybe in the future, there'll be better tools to implement that will help this process. And on the other hand, we have countries where there is extensive digital documentation required, like in the US, and there are papers which have come out talking about EMR burnout and doctors who are getting tired of digital formats to support. So I think there is a judicious benefit in using there is benefit in judiciously using it. You should know why you're using it and what the purpose is, and make sure that finally, at the end of it, the patient gets what they want. One is that they should get attention. Two is that somebody should be there to provide the care that they require. Remember, people come to us when they're most vulnerable and they have problems. So sometimes paying attention to the patient, touching the patient, examining them, and a sympathetic ear is more important than digital capture of data.
Thank you, Dr. Joy. I think that's the questions that we have received. But if there are any questions that you all want to ask, let me just so that you will be able to unmute yourself and ask, or you can put it on the chat box if there are any. Any more questions from the participants? So if there are no, we can wrap up here. And at this point of time, I want to extend a sincere thanks to you, Ms. Anisha and Dr. Joy, for your clarity on such a complex subject. We know that it's still emerging and we're still getting to learn more, and there's a lot more to learn and a lot more to unravel in this unwrap in this area. And we want to thank all the participants for your active engagement today. And this conversation is just the beginning. And please mark your calendars for our next installment, where we will look into a few case studies. And hopefully it will be somewhere around 16th of July. We do it usually on Thursdays. So we'll look into specific case studies and the operational changes that is required at the hospital level to stay compliant while providing excellent care. So thank you for joining us. Have a productive and meaningful evening. So we'll conclude the session here. Thank you all for joining. Thank you so much.
Thank you. Thank you, Dr. Joy.
Thank you, Rupa. Thank you, Abhijit.
Thank you.
Thank you.